in the hormone receptor positive setting, which you all already nicely laid out your treatment paradigm there, I think, yes, the question does come up quite a bit with regard to sequencing the CDK4/6 inhibitor with a PARP inhibitor. And just practically speaking, as you pointed out, trial design really logistically allows us to give the PARP inhibitor first and then save the CDK4/6 inhibitor for later. But I think it's interesting as we try to reconcile the varying inclusion criteria across the adjuvant CDK4/6 inhibitor trials. We now have ribociclib and we have abemaciclib labeled in the adjuvant setting. With the Olympia inclusion criteria, there's subtle and not so subtle differences between the hormone receptor positive populations that were included. And so in a busy sort of practice, would you say that if you think your patient is high risk enough to use a CDK4/6 inhibitor and they have a germline BRCA alteration, then go with the PARP inhibitor first and then sequence the CDK4/6 inhibitor? Or is there value to really sort of subtly parsing out the various inclusion criteria? And perhaps there are some patients who you're giving a CDK4/6 inhibitor to and not a PARP inhibitor. This is sort of a long and convoluted question, but yeah. I think my general paradigm is if I feel that they're high risk enough for an adjuvant CDK4/6 inhibitor and we identify a germline BRCA mutation, then I typically do use a PARP inhibitor as my first therapy with endocrine therapy in that setting. But I'm curious with regard to your thoughts, because these are sort of subtle differences between trials.
Yeah, I think that that's a very important point. Like we were talking about at the beginning, the criteria for Olympia were designed to risk stratify, not because there was a biological difference between somebody who had 3 nodes and 4 nodes, right? So, it was purely a risk stratification for the purposes of trial design. And I think what you're trying to do in the clinic is find a person who has sufficient risk that they may benefit. And if I recall, the label actually for Olaparib is high risk. The Olaparib doesn't talk about the entry criteria for Olympia.
It's sort of broadly, you define it.
Exactly.
Labeling, right?
Exactly.
Yeah.
So Olympia defined safety and efficacy. Mm. And then now the clinician is the one who makes the decision about whether or not the risk is sufficient to potentially generate benefit. Mm. And so your paradigm of if they got enough risk for a CDK4/6 inhibitor, they got enough risk for a PARP inhibitor, makes perfectly good sense to me. Mm. It's kind of like what we used to do in clinic, right? If they had enough risk for chemo, they probably had enough risk for ovarian suppression. It was the same kind of paradigm, just a very straightforward algorithm. So I think that's a good way to look at it.